Welcome to the William Hitselberger Memorial Lecture. Before I ask Dr. Hertzano to introduce our guest lecturer, just a minute of remembrance of Dr. Hitz. He went to medical school at Harvard Medical School. After serving an internship in Minnesota, he served his country as a captain in the U.S. Army Special Forces. He did his neurosurgery residency at Henry Ford Hospital and then went into practice in Los Angeles, where he joined the House Ear Clinic and for over 30 years trained neurotology fellows, developed surgical approaches to the skull base, and took out approximately 6,000 acoustic neuromas. No one has taken out more acoustic tumors than Dr. Hitselberger. Dr. Hitz passed in February of 2014, and his ashes were laid to rest at Arlington National Cemetery in a wonderful funeral that I know several of our neurotology colleagues attended. Dr. Hitselberger was truly a giant in his field. He partnered well with the neurotologist. There was no tension between neurotology and neurosurgery when you went to the House Ear Clinic, and that's what made the system go. And he had a wonderful personality, and I truly had the privilege of training under Dr. Hitze. He is definitely missed. So with that, I would like to introduce Dr. Ronna Hertzano, who is the chair of the research committee. And Dr. Hertzano, before you introduce Dr. Cunningham, I'd like to publicly acknowledge all the hard work that you have put into the research committee for the ANS, whether it's reviewing grant applications, reviewing papers for awards, for panels. Thank you for your time and your effort and your dedication to the society. Very much appreciated. And Dr. Cunningham, we're very much looking forward to your talk. So thank you.
For the support of the research committee. It's a real pleasure to introduce Dr. Cunningham today. Dr. Lisa Cunningham will be presenting the Hitselberger Memorial Lecture, and she originally trained as a clinical audiologist and then pursued a PhD and postdoctoral training in neuroscience, where she focused on the molecular basis of ototoxicity. When Dr. Cunningham established her own laboratory at the Medical University of South Carolina, she pioneered understanding the role and the mechanism of action of heat shock proteins in otoprotection. Once she was recruited to the NIDCD in 2011, her work took a translational turn with a three-pronged approach to develop therapeutic targets and strategies to safeguard hearing. Dr. Cunningham conducts groundbreaking interdisciplinary studies to understand the basic mechanism of cisplatin-induced ototoxicity, followed by translational work in animal models, and most recently, clinical studies. As I'm sure Dr. Cunningham will share with us today, her most recent work suggests that some common, affordable, and well-tolerated FDA-approved drugs can reduce cisplatin-induced ototoxicity by up to 50%. Dr. Cunningham is also a fantastic collaborator and mentor, repeatedly awarded NIH mentorship awards, and is a mentor of several of the surgeon scientists in our society, including Drs. Wei Chen and Michael Hoa. Finally, most recently, Dr. Cunningham was selected as the next scientific director of the NIDCD, a significant leadership position where she will oversee and function as the director of all of the NIDCD laboratories on NIH campus, also known as the intramural program. Lisa, thank you for accepting our invitation. It's a great honor to have you today. I'm looking forward to your talk.
Thank you so much, Brad, for the invitation. It's a privilege for me to give this lecture in the memory of Dr. Hitselberger, and thank you for giving us some notes on his remarkable career. Thank you also to Ronna Hertzano for the generous and kind introduction. I'm excited to have the opportunity to talk to the Neurotology Society today about our work on Atorvastatin and its relationship with cisplatin-induced hearing loss in patients with head and neck cancer. I have no financial disclosures. I will be discussing a potential off-label use of an FDA-approved drug, which is Atorvastatin. I like to begin with the mission of our laboratory, which is that we conduct basic translational and clinical studies aimed at understanding and preventing hearing loss in the mature inner ear. So this is acquired hearing loss. Our basic studies are designed to examine the cellular and molecular mechanisms that underlie ototoxic drug-induced sensory hair cell death in the inner ear and the survival of those hair cells when they're under stress. Our translational studies are designed to then use that basic science knowledge in an effort to inform the rational design of therapies aimed at preventing drug-induced hearing loss in humans. And then our clinical studies are designed to test the efficacy of these potential protective therapies in humans who are undergoing life-saving therapy with ototoxic drugs. So I'd like to give you just a flavor of these three types of work that we're doing. And I'll begin with our basic science work where we're looking at mechanisms. And one of the mechanisms of interest that we've been studying for the last 10 years or so is around the question of what are some of the intrinsic protective mechanisms that cells, particularly hair cells, can induce when they're under stress from a variety of stresses, but in particular from these ototoxic drugs. So for over a decade now, my lab has been studying, as Ronna indicated, a class of protective molecules called heat shock proteins. Heat shock proteins are a family of evolutionarily conserved stress response proteins that promote cellular survival. So they were originally named because they are induced by heat, which is a stress that will kill any cell type. But we now know that that's not really a great name because heat shock proteins are induced in response to a wide variety of stresses. And in fact, virtually anything that stresses a cell will result in heat shock protein activation. When a cell is faced with these environmental stressors, it results in transcriptional induction of heat shock protein expression. And these heat shock proteins then have a variety of anti-apoptotic effects and are protective against cellular death in a wide variety of systems. So many years ago, we asked the question, can heat shock protein induction reduce hair cell death caused by ototoxic drugs? And to address this question, we used a model, an in vitro preparation of whole organ cultures of utricles from adult mice. This utricle preparation is the best characterized model system for studies of mature mammalian hair cells and supporting cells in vitro. And what we did in this preparation is we used these mouse utricles to induce heat shock proteins. And to do that, we used a classical heat shock manipulation where we warmed the tissue a few degrees for a short period of time. Not enough to kill the cells, but enough to induce these proteins. And you can see in this Western blot that this heat shock manipulation results in robust induction of some heat shock proteins, including heat shock protein 70 and heat shock protein 32. We then asked if this heat shock protein induction is protective against cisplatin-induced hair cell death. So in this graph, you can see increasing cisplatin concentration on the x-axis and hair cell survival on the y-axis. And so in the absence of heat shock, we can see that hair cell survival progressively decreases as cisplatin concentration increases. However, if we heat shock the tissue prior to the addition of cisplatin to the culture medium, we see a robust protective effect against cisplatin-induced hair cell death across the cisplatin dose-response relationship. So these and many other studies that I don't have time to show you indicated to us that induction of these heat shock proteins can reduce cisplatin-induced hair cell death, and we had also shown that these heat shock proteins could reduce cisplatin-induced hearing loss in animal models. So our basic science studies have shown that heat shock protein induction is protective against ototoxic drug-induced hearing loss and hair cell death. In order to begin to translate these studies into protective therapies against ototoxic drug-induced hearing loss in humans, we wanted to ask the question, are there FDA-approved drugs that are known heat shock protein inducers? We felt that if there are FDA-approved drugs that are known to induce these proteins, those drugs could potentially be rapidly translated into clinical use to reduce hearing loss in patients receiving these drugs. And so it turns out that a familiar class of drugs that are commonly known as statins are known inducers of heat shock proteins. So statins, of course, are widely used drugs that are used to reduce cholesterol in individuals who are at risk for cardiovascular disease. And in addition to their known effects on cholesterol, formation in the body, statins are robust inducers of heat shock proteins. So we were excited to take a look at statins because this is a class of drugs that are widely used, and they have very good safety profiles in humans. So we were enthusiastic to take a look at whether statins could reduce cisplatin-induced hearing loss. We knew from other studies that statins were potential candidates for reducing ototoxicity, and I'll just briefly describe some of those studies here. As I indicated, statins are known inducers of heat shock proteins, and other laboratories had already shown that some statins reduced hearing loss caused by other types of stresses, either in vitro or in animal models. For example, simvastatin reduces aminoglycoside-induced hair cell death in vitro. Pravastatin reduces noise-induced hearing loss, and atorvastatin reduces age-related hearing loss in mice. So Kate Fernandez, who is an audiology clinician scientist who works in our laboratory, asked if lovastatin can reduce cisplatin-induced hearing loss in mice, and she showed that it does. And I'd like to just briefly show you those data. So in order to do this experiment, Kate first had to develop a mouse model of cisplatin ototoxicity, and that was a bigger challenge than we expected, and it took several years. So I'll just show you in this schematic how this experiment was performed. We first test the hearing of the mice using auditory brainstem responses and distortion product otoacoustic emissions. Then the mice receive cisplatin systemically for 4 days, and then there's a 10-day recovery period. And this 4 days of cisplatin administration and 10 days of recovery period constitutes a single cycle of cisplatin administration. Mice undergo 3 cycles of cisplatin administration before we again test their hearing with ABRs and DPOAEs, and we report the change in hearing as a threshold shift, which is the difference in the baseline hearing test and the follow-up hearing test. For this particular experiment, Kate administered lovastatin to the mice for the entire time that they were undergoing cisplatin therapy. So here are the data. Kate has broken these down here in female and male mice. And on the y-axis of these graphs, you see threshold shift. That is increasing hearing loss, or the difference between the baseline hearing test and the follow-up hearing test. And you can see that our control animals, which only receive saline, do not get a hearing loss. However, our animals who underwent these 3 cycles of cisplatin administration have a significant hearing loss that is worse in the high frequencies than in the low frequencies. So this hearing loss looks similar to the cisplatin-induced hearing loss that we see clinically. In both male and female animals, Kate saw a significant protective effect for mice that also received lovastatin. However, there are some interesting sex differences here. As you can see, we saw a slightly better protective effect of lovastatin in the female animals compared to the male animals. And in addition, the female animals required a higher dose of lovastatin to be protective. The female animals showed protection at 60 milligrams of lovastatin, and the male animals showed protection at 40 milligrams of lovastatin. Frankly, neither of these protective effects were super exciting because they weren't complete protection, but they were enough protection for us to be enthusiastic about taking a look to see if we could determine if there is a relationship between statin use and cisplatin-induced hearing loss in humans. So our translational studies showed that statins are protective in animal models. So in order to translate these data into a clinical therapy, we decided to ask if we could examine the effects of statins in humans in an observational study. We reasoned that a number of adults, a high number of adults, especially in the United States, are already taking statins, and we should be able to find audiograms of individuals who have undergone cisplatin therapy who are also taking statins. That turned out to be a little harder than we thought, significantly harder than we thought, to be honest. And so what we wound up doing is we had combined retrospective and prospective observational study. It turns out that routine ototoxicity monitoring in adults who are receiving cisplatin therapy is pretty rare. And so we needed to find collaborators who could provide us with reliable baseline hearing tests close to the time that someone underwent cisplatin therapy, and then also a reliable follow-up hearing test. And what we were looking for is baseline hearing tests within 90 days of the onset of cisplatin therapy, and then follow-up hearing tests within 90 days of the completion of cisplatin therapy. And we were able to collaborate with two institutions that had robust ongoing ototoxicity monitoring programs in order to do this. And those were the University of Rochester Medical Center and Walter Reed National Military Medical Center, which is across the street from us at NIH. In addition, while we were collecting these data, we instituted our own prospective observational study in collaboration with Dr. Nicole Schmidt, who is at Emory Winship Cancer Institute, and Dr. Kate Fernandez, who is the audiology staff scientist who works in our lab. And so I have to say that this collaboration with Dr. Schmidt and Dr. Fernandez has been an absolute pleasure, and we have worked very closely together on every aspect of this project. In the end, among the 4 institutions, we were able to collect data on 277 subjects, 113 of whom were already on a statin drug and 164 of whom were not taking a statin drug. All of these patients were adults. They were all newly diagnosed with head and neck cancer, and they were all scheduled to undergo cisplatin-based chemoradiation therapy. We had to exclude subjects who had profound hearing loss at baseline because we would not have been able to measure a change in their hearing after their cisplatin therapy. So I'm excited to show you how this project went. Oh, I did want to indicate that one of the challenges that is faced for ototoxicity monitoring is the timing of the hearing tests and also the availability of audiology resources. And we discovered in our prospective study that we really could make the ototoxicity monitoring more feasible in the busy clinical settings that were collaborating with us by using some form of portable hearing testing. There are several types of these portable hearing test equipment, and we elected to use a system called shoebox audiometry. I don't have any relationship with shoebox audiometry. There are a number of these types of portable hearing testing. But this is an iPad-driven, it's a self-administered hearing test. It comes with calibrated headphones, and this system will measure the ambient room noise in the room before the subject takes the hearing test. And if the room isn't quiet enough, the hearing test won't proceed. So we were able to find some quiet rooms in our clinic spaces and actually test the hearing of the patients in our prospective study in the radiation oncology clinic during one of their routine visits. So that made it a lot more convenient for our participants. So here are the subject and treatment characteristics of our subjects. Again, these were patients with head and neck cancer, so their median age was about 60 years old. They were primarily male. They received a median cisplatin dose of 200 mg per meter squared, and 98% of them, or 99% of them, also received cranial irradiation. We looked at the hearing loss, the baseline hearing tests, and about 80 or 85% of our subjects had either normal or only a mild hearing loss at baseline. So that gave us a lot of room to look at changes in hearing. So again, we measured the hearing loss in terms of threshold shift, which is the difference in the baseline hearing test and the follow-up hearing test. And these are the frequencies that we tested, which included some high-frequency audiometry, which we know are the frequencies that are first affected by cisplatin ototoxicity. So you can see here that among our individuals who did not take statins, we saw reliable high-frequency sensorineural hearing loss that is pretty typical of what we see for a cisplatin-induced change in hearing. However, when we compared our individuals who were not taking any statin to the individuals who were taking any statin drug, we could see a significant protective effect, especially in these high frequencies where the cisplatin-induced hearing loss is worst. So this was the beginning of our excitement about statin use for cisplatin-induced hearing loss. So because this was an observational study, we didn't have any control over what statins were being used by subjects in our cohort. And so we discovered that there were 6 different statins in use by our subjects. And only one of those statins, which was Atorvastatin, did we have enough statistical power to examine that statin individually. So Kate also analyzed Atorvastatin use compared to individuals who were not taking any statin drug. And when she did that, she could see an even greater protective effect in the atorvastatin users compared to our any statin user group. And the atorvastatin users had significantly less hearing loss than those who were not taking any statin drug. And in fact, the atorvastatin users, the mean hearing loss for those individuals hovers around 5 decibels, which is usually considered test-retest reliability for an audiogram. So some of the atorvastatin users are really approaching no hearing loss here. So Kate went on to use a mixed effects model to examine other factors that we know influence cisplatin-induced hearing loss, including sex and age, and cumulative cisplatin dose, radiation, and pre-existing hearing loss. And even when she accounts for all of these other factors that we know can influence susceptibility to cisplatin-induced hearing loss, she still saw a significant relationship between atorvastatin use and reduced cisplatin-induced hearing loss. So we wanted to look at the incidence and severity of cisplatin-induced hearing loss in our cohort. And to do that, we applied a grading scale developed by the National Cancer Institute. And this grading scale is called the Common Terminology for Criteria for Adverse Events, or CTCAE. This is a grading scale that the National Cancer Institute developed to grade any type of adverse event in a clinical study. And those can include anything from, a rash to a heart attack to a stroke to death from the adverse event. And so, fortunately for us, hearing loss is not an adverse event that can occur in grade 5. No one dies from a hearing loss. But we looked particularly at these grade 0 to 3 hearing losses, and I will point out that grade 1 is considered a mild hearing loss where an intervention is not indicated. Grade 2 is a moderate hearing loss where we might need a hearing aid, and grade 3 is a severe or disabling hearing loss. So these are the criteria that we applied to the data in our observational study. And when we applied those data, we found that the atorvastatin users had a reduced incidence and severity of cisplatin-induced hearing loss. So the first thing that I'd like to point out is that the grade 0s, which is no hearing loss, was about 50% in our non-statin users. So that means that half of our head and neck cancer patients had a cisplatin-induced hearing loss, which I think is probably a higher incidence of cisplatin-induced hearing loss than we expected in our head and neck cancer patients. You can also see that these more severe hearing losses, these moderate and debilitating hearing losses, went from about 30% of our head and neck cancer patients treated with cisplatin who were not taking a statin to only about 10% of our head and neck cancer patients who were taking atorvastatin. So this again was a significant reduction in both the incidence and severity of cisplatin-induced hearing loss in patients who were taking atorvastatin compared to those who were not taking any statin drug. Of course, it's critically important when we think about developing a treatment that would reduce cisplatin-induced hearing loss that we examine the potential for that protective treatment to interfere with cisplatin's ability to do its job, which is to kill cancer cells and save lives. And so we had incomplete data to address this question, but we did look at overall survival and disease-free survival in our largest cohort, which was our retrospective cohort. And we saw no difference in either overall survival or disease-free survival at the 3-year mark among our non-statin users, our any statin users, or our atorvastatin users. And in fact, there are some large epidemiologic studies that have shown that statin users don't have worse outcomes with their cancer therapy compared to non-statin users. So these data were encouraging to us because together with our hearing loss data, they suggest that atorvastatin is associated with reduced cisplatin-induced hearing loss in our head and neck cancer patients without altering overall survival or disease-free survival. So in order to definitively determine the extent to which atorvastatin can reduce cisplatin-induced hearing loss, we of course have to conduct a phase 3 study, and we are initiating this study now. So we're initiating a phase 3 study to determine if atorvastatin reduces cisplatin-induced hearing loss in our patients with head and neck cancer. This study will be, again, all adults with head and neck cancer. They will all be scheduled to receive cisplatin chemoradiation. And while we will enroll subjects who are taking a statin in an observational study, the interventional part of this study will include individuals who are not taking a statin drug at the time that they enter the study. So we need 186 subjects who are not taking a statin drug. Those subjects will be randomized to either 20 mg of atorvastatin or a placebo. Again, we will get baseline audiograms using a shoebox audiometry system within 90 days prior to the onset of cisplatin chemotherapy. Our patients will undergo their full course of cisplatin chemotherapy, and we'll do a follow-up audiogram, and then we will compare again the follow-up audiogram to the baseline audiogram. In this study, our primary outcome is the incidence of a grade 2 or greater hearing loss using the CTCAE criteria, and our secondary outcome will be 2-year survival. The current state of this study is that it has undergone scientific review at NIDCD. We received an NIH Bench to Bedside Award for this project, and we've just received our first pass at our IRB review. So I'd like to see us begin to enroll subjects in this study toward the end of this year. So in terms of conclusions, our basic science studies have shown that heat shock protein induction is protective against ototoxic drug-induced sensory hair cell death and hearing loss. Our translational studies indicate that statins are protective in animal models of ototoxic drug-induced hearing loss. And our clinical studies indicate that atorvastatin users have reduced cisplatin-induced hearing loss compared to non-statin users. And we are currently initiating a phase 3 study to determine the extent to which this is true. So I have to show you several pictures in order to show you all of the wonderful people who have worked on this project over the years. I'm extremely fortunate to work with this very, very talented group of dedicated scientists and clinicians. Again, I appreciate the invitation to talk with you, and I'd be delighted to take your questions.
Thank you, Lisa, for this excellent talk. And there are a few questions in the chat box. First, there are a couple of questions asking about the incidence of tinnitus in atorvastatin.
So we administered a tinnitus index in our prospective study, but our prospective study was the smallest group that we had. There were I think about 30 subjects in the prospective study. So the rest of it was retrospective. So we don't have adequate data on tinnitus in the observational study. We are looking at the best mechanism for collecting tinnitus data and some other patient-reported outcomes that we're interested in for the interventional study.
Thanks. Okay, so the next question is if you've done a multivariate analysis of the effect of atorvastatin, considering other comorbidities of patients that may contribute to the outcome.
So one of the challenges that we had, so the short answer is no, but one of the challenges that we had with the retrospective study is that in general, there are not, it came as a surprise to us, there are not large audiometric databases that are tied to the medical record. And this is a significant need in our field, in my opinion. We need to be able to ask questions exactly like the person who posed this question. Since we have published this study a couple of months ago, we've received questions like, were you able to look at the effect of diabetes in your study? Were you able to look at the effect of this other drug that I'm interested in? Were you able to look at whether cholesterol actually had whether the effect was actually related to a reduction in cholesterol? And the problem is, because it was a retrospective study and because the audiogram is not really tied in a robust way to the medical record, we weren't able to ask these types of questions. So moving forward, we hope to be able to have a robust system that can link our study to the relevant medical record. And really our field needs robust databases like that so that people can go and ask questions like this question.
Terrific. There are more questions. One question is, in your opinion, how much time in advance of the first treatment with cisplatin would patients need to be getting the statins?
So we don't know the answer to that. The only thing that we know in our retrospective study, we considered someone a statin user if they were taking statins on the first day of their cisplatin chemotherapy. And we considered them a non-statin user if they were not taking cisplatin at the time of initiation of cisplatin therapy. So we don't know. We assume that there was a large amount of variability in how long people had been on the statins. In the animal study, we didn't preload lovastatin. And so the animals were only on the lovastatin for a short period of time relative to the onset of cisplatin. So in the interventional study, we'll of course be able to control the amount of time that someone was on the atorvastatin prior to the initiation of cisplatin therapy, and it'll be a pretty short period of time.
Thank you. So there's a question, are there any studies that looked at vestibular toxicity as a result of cisplatin?
We are starting to think about how to do that. The literature is not very revealing about vestibulotoxicity in patients undergoing cisplatin therapy. In our animal model system, we don't see any, we don't see any change in the vestibular evoked potential, and we don't see any loss of vestibular hair cells. But we are discussing right now with Chris Zaleski, who's an expert on testing vestibular testing in humans, how we might go about conducting a study to determine the extent to which cisplatin is vestibulotoxic in humans.
All right, terrific. Well, thank you so much. This was a fantastic talk, and I think we'll have to move on to the next item on the agenda.
Thank you, Ronna.